Okay,
Yes,
ma'am.
and started the timer. Here is your question. Right. So if you have read and understood, considering its surgical administration, kindly please identify what are you looking at.
This is the CT scan of the abdomen.
Yes.
Showing the
Showing which organs? Can you identify, yes, A to E?
A is the gallbladder.
Yes.
B, I'm not sure. C is the superior mesenteric artery. D is the left lobe of liver, and E is the pancreas.
Okay. All right. Can you identify this organ over here?
This is the right kidney.
Okay. What about this organ here?
Spleen.
Okay. Can you tell me the parts of spleen, please?
Spleen has mainly two surfaces and two borders: the diaphragmatic surface and the medial surface.
Yes.
And upper superior border and the inferior border. On the superior border, it has a splenic notch, and on the medial surface, it is related to the stomach, kidney, and also the colic impression.
Okay. Can you please tell me the blood supply of the spleen then? Both arterial and venous.
Spleen is supplied by the splenic artery and the splenic vein. Splenic artery is branch of celiac trunk, and the splenic vein is vein drains into portal vein after joining with the superior mesenteric artery. Sorry, superior mesenteric vein.
Yes. Okay. Can you please tell me this spleen is the surface anatomy of spleen?
Spleen. It lies it lies in the left hypochondrial region, opposite 9th, 10th, and 11th rib.
All right. Okay. Can you tell me, while doing splenectomy, which part of spleen which is variable?
Which part of spleen is viable?
Variable.
Variable, ma'am.
Yes, variable. It's not steady, it's movable or variable. Its location cannot be perfect.
I'm not sure, ma'am.
It's the tail. Okay, can you please tell me the course of splenic artery?
Splenic artery, it originates from the celiac trunk and runs to the left side along the upper border of the pancreas behind the stomach, separated by the lesser sac, and then runs into the linorenal, into the linorenal ligament, and then terminates into its terminal branches in the hilum of the spleen.
What are the organs which are supplied by this vessel?
Splenic vessels.
Artery, yes.
It mainly has supply to the pancreas and the fundus of the body and the fundus of the stomach and the spleen.
Yes. Okay. Can you identify this organ over here? Which organ could that be? Or
So-
can you guess at what level this CT scan transection has been taken?
L1 level.
Are you sure? Would you find spleen at L1 level? You have to think. Okay, can you identify this image, please?
It is the CT scan of the abdomen.
Yes, now
Uh,
it is at what level, please?
It is at
What are the organs that you can see clearly?
you can see the
What are these? Can you identify them?
right kidney, left kidney,
All right, what is this F pointing
abdominal
at?
aorta. It is the fundus of the stomach.
Which organ is G?
G is the abdominal aorta.
All right, what is B?
B is the paraspinal muscles.
Yes. Okay, what is C?
C
Could
is
that be-
the
Yes. All right, if you can tell me, just suppose there was pancreas and you identified it correctly. Can you tell me the parts of pancreas, please?
pancreas has head, neck, body, tail,
Yes.
and the uncinate process.
All right, good. Can you tell me the blood supply of the pancreas?
Pancreas is mainly supplied by superior pancreaticoduodenal branch from gastroduodenal artery, inferior
Yes.
pancreaticoduodenal from superior mesenteric artery,
Yes.
and the pancreatic branches of splenic artery.
Good. Can you please tell me how many ducts open in pancreas and at what levels?
It has mainly two ducts, the major
Yes.
pancreatic duct and the minor pancreatic duct. The major pancreatic
Minor or
duct,
accessory? Okay, yes.
minor or accessory, major duct, the main pancreatic duct opens in the major duodenal papilla, and the
Yes.
minor or accessory in the minor duodenal papilla. The major duodenal papilla lies on the postural medial aspect of the second part of duodenum, 8 to 10 centimeter distal the pylorus.
Okay. Duodenal papilla. All right. Okay. Can you please tell me what are the ligaments which connect the tail of the pancreas to the spleen?
It is the linorenal ligament.
All right. Good. Can you please tell me the development of embryological development of the pancreas?
Pancreas is developed from two buds, the ventral bud, ventral pancreatic bud, and the dorsal bud.
Yes.
The ventral bud develops from the hepatic diverticulum, and it gives rise to the head and the lower part of the uncinate process. And the major portion is developed from the dorsal bud, which gives rise to head, neck, body, and tail of the pancreas.
All right. Good. Can you please tell me the interior relations of the head of the pancreas? Just imagine. Yes. Close your eyes. Imagine. What are the interior relations? At what level is the head of the pancreas located?
Pancreas is located at the level of number one level.
Yes. Okay.
And anteriorly it is related to the pylorus in the first part of duodenum.
All right.
And
what are the vessels? Which are in front? Yes.
In front of the uncinate process, we have the superior mesenteric vessels.
Okay. And these relations are very important, right? So
yes, ma'am.
Yes, this is the only thing that you couldn't. So please go through those.
Okay, ma'am.
Yes, and yeah, they'll ask you to identify, and then they'll ask you these sort of questions like I did. So thank you so much. Right. So if you have read and understood, considering the critical care scenario, kindly tell me how do you plan to manage this patient now?
Okay, I will manage according to the advanced trauma life support.
Yes.
I will check an airway. If this patient can speak, then proceed. If it's with this, then I will
If patient
go.
can speak, can I interrupt you, please? And you realize patient has an open fracture and patient is bleeding a lot. What would you do first? Would you go ahead, still make sure airway is patent and breathing and all that, or you'll go ahead and you'll try to stop the bleeding? What would
Okay,
be your
if
mode of action? Yes.
patient can speak, will stop any source of bleeding. I will insert 2 line per cannula.
Yes.
I'll start fluid resuscitation with 2 liter crystalloid.
Yes.
I will to run some investigation, urea and electrolyte and ABG. I will do cross matching.
Yes.
If no response to fluid, I will consider blood transfusion with 4 units of blood. Also, I will assess for pulse rate and blood pressure and capillary refill.
Yes. What else would you remember to do in that situation when patient is not responding and you have to be sure?
I will assess the class of hemorrhage.
That you'll do, but you'll also do the chest X-ray to make sure if there is any bony trauma to the rib cage,
Okay.
etc., which can maybe lead to a pause. Okay. How much fluid would you give to the patient? Because here I said patient is having difficulty in breathing, so maybe there could be some rib fractures or something. So to rule out that. Okay. How much fluid would you?
I will give 2 liters of crystalloid.
Okay. And how much as a maintenance dose should be given per hour? Considering patient is 70 kg of weight.
300 milli per hour.
We will discuss that. Can you please tell me how would you monitor or how would you keep the record of if patient is responding to the fluid management that you are giving?
We'll start give blood transfusion.
How would you monitor if patient is
Okay, I will
responding or
manage.
not?
I will check for pulse rate and
Yes.
blood pressure and
Yes.
capillary refill and mental state.
And urine output as well. Very
Urine
important. Okay. Right. If patient is not responding, how you said you will give the blood transfusion as well? Would you go for the full whole blood count, or you will go for in particular fresh frozen plasma or something?
I'll give packet RPCs.
Packed RBCs. Okay. Why? What is the benefits of giving packed RBCs over giving the fresh frozen plasma or the whole blood? Please give 3 reasons. Yes. Okay, pass. So can you please tell me how would you evaluate if patient is having hemorrhagic shock or not? How would you rule out?
I will assess hemorrhage if it's less than 750.
Okay.
Class 1.
Blood loss. All right.
Class 2 with
anything else?
Yes, 750 to 1050.
Yes.
This class 2 between 1500 to 2000. This is class 3 more than 2000. This is class 4.
Yes.
I will check for pulse rate. If it's less than 100, this class 1 between 100 and 120. This class 2 120 to 140.
For this patient, can you calculate and tell me patient had pelvic fracture and open tibiofibular fracture. Right. So what grade of
Yes.
shock is patient in right now?
Is most likely to have grade 4.
Okay, yes, quite possible. Then, yes, and patient is unconscious as well. I wanted you to tell me this as well, that you will also
Yes,
consider the mental
lethargic.
status. Yes, okay, right. Can you tell me that if you do CT scan, do I have it? No, I don't. Okay, if you'll do the CT scan to rule out what and why, would you or not? Patient is unconscious.
No,
It's RTA.
this is patient is RTA. This patient is in shock. This I will go for fast scan.
Okay, good. All right, good. Okay. Can you please tell me where would you manage this patient?
In the intensive therapy unit.
Yes, and who would you involve in the management of this patient?
The general surgeon and the anesthetic consultant and the orthopedic surgeon.
And would you send the call for plastic surgeon or not?
Yes,
Plastic
I will
and
call him.
vascular maybe. Okay. Would you intubate the patient right away, or what would you do? Can you please tell me the whole plan of management? Because patient is unconscious.
I will check if patient. Then I will feel and look and listen.
Yes.
I will look for any obvious maxillofacial fracture.
Yes.
Then I will feel for. I will listen to any breath sound, abnormal breath sound such as stridor and wheezing or snoring.
What may cause stridor
I
in this patient?
foreign body maybe.
Yes. Okay. Yes. What would you do then?
Then I will remove it, or I will insert oropharyngeal airway with high flow oxygen. If no response, I will consider intubation. If there is a maxillofacial fracture or edema, I will consider cricothyroidotomy with trichostomy set.
All right. If you'll intubate, what are the risks that you should keep in your mind?
Patient may have laryngeal edema.
Okay. Anything else?
Or maxillofacial fracture.
All right. Anything else? How would you determine how much partial pressure of oxygen should be? How would you set the ventilator? How would you make sure that it's adequate? Patient can have the risk of hypoxia and
I will do
aspiration as well.
ABG.
Okay. Yes.
And pulse oximeter.
Yes. So what would you do? What measures would you take to prevent aspirations from aspirations happening?
I will do chin tilt and throat chest firstly.
Anything else? Any tube you'll insert for toileting?
Yeah,
maybe?
the section.
Yes. Okay, good. The problem is, but you talk less. I don't know why. You know the station and you know the answer. Here is your question. Right, so if you have read and understood, considering its surgical pathology station, kindly tell me this patient had colonoscopy done and it revealed that she has multiple polyps. What do you interfere from this pathology report?
Okay, what I infer from this pathology report is...
Yes, please.
Okay, what I infer?
Yes, please. How do you interpret it? What is your thinking that could be the provisional diagnosis?
Okay, the provisional diagnosis, it could be a familial adenomatous polyposis, it could be a juvenile polyp, it could be
She's 23, she's adult. Yes.
Yeah, okay, it could also be apart from familial adenomatous polyposis, it could be hematomatous polyps like Creutzfeldt's syndrome. It could also be bronchitis Canada syndrome. It could be Cowden's disease.
Okay, good. All right. Can you tell me how would you confirm your diagnosis?
Okay, to confirm my diagnosis during the section of the colonoscopy, I want to take the I want to do polypectomy and send the sample for histologic confirmation to check if there is any dysplasia or something else within the body.
Okay. Can you tell me what are the genes which can be involved in FAP?
The gene that can be involved in FAP is the APC gene.
And
adenomatous polyposis coli gene. Also, we can have the KRAS gene, the DCC gene, DPC gene, and P53 genes.
Okay. Can you please tell me how proto-oncogenes and tumor suppressor genes they act?
Proto-oncogene is the normal genes which are responsible for cell proliferation. But when they get mutated, they become oncogenes. They are activator genes. Why tumor suppressor genes? These are inhibitor genes which inhibit cell proliferation and differentiation.
All right. Okay. Can you please describe these genes are most likely to form or have the transformation and they can cause carcinoma. So can you please tell me what are the types of cancer causing genes that are present here?
What are the sorry, ma'am?
Types of cancer causing genes?
Okay, the types of cancer causing genes are the APC gene, the KRAS.
Okay, oncogenes.
Okay, oncogenes, the oncogenes, example of oncogene is the KRAS, while the tumor suppressor genes are the APC, the DCC, and the P53 genes.
All right, okay. Can you please tell me what are the types of carcinomas that it can cause?
What are the, sorry,
types of adenomas that can be caused because of these genes?
Okay, the types of adenoma could either be neoplastic and non-neoplastic adenomas. The neoplastic adenomas are the neoplastic polyps are the adenomas, the adenomatous polyps. Then while the non-neoplastic polyps are the inflammatory polyps, hyperplastic polyps, the hematomatous polyps, and sessile serrated polyps.
Out of these all polyps, which one is most likely to cause malignancy?
The one that is most likely to cause malignancy is the adenomatous polyps.
Villus. Villus one, neoplastic one.
Yeah, the villus type of the adenomatous.
Okay, can you please tell me?
Accounts for 40%. Yes, ma'am.
The malignant potential of adenoma depends on what factors?
The malignant potential of adenomatous polyp depends on the type of the polyps, of the adenomatous polyps, and the size of the adenomatous polyps. Villus adenomatous polyps account for 40%, has a higher potential of malignant transformation. While in terms of sizes that are greater than 2 centimeters have a higher chances of becoming malignant.
Okay, good. Can you please tell me what are, according to, okay, how would you classify the extent of carcinoma? Or basically, I want you to tell me the classification. How would you classify the adenoma?
Adenomas can be classified, can be villous,
Yes, but then,
tubulovillous, and villous.
yes,
Yes,
like
ma'am.
Duke's classification and TNM.
Okay, there are different types of classification of this cancer. It could be by there's Duke's classification, there is modified Duke's by Aslacola, and there's also Aslacola's, modified Aslacolas, and then we also have the TNM. The most commonly used one is the Duke's classification.
Yes, I wanted to know that actually.
Okay.
Yes.
Okay. Duke's is divided into A, B, C, and D, ma'am.
Yes.
A is when it's limited to the mucosa. B is when it invades the muscularis propria. C is when it invades.
Right,
B is when it invades the wall. Then C is when it involves the lymph node, and D is when there is distant metastasis.
All right. Can you name few extracolonic FAP presentations?
Ma'am, sorry, ma'am.
Extracolonic FAP presentations. Other
Okay,
than like yes.
Okay, the extracolonic FAP presentation includes the Gardner syndrome, Tokut syndrome, and Oldfield syndrome. In the Gardner syndrome, it's FAP when there is multiple polyps within the GIT, in addition to mandibular osteomas. We have sebaceous cysts, and then the dermoid cysts. Then for the Tokut syndrome is when there is multiple polyposis within the GIT, in addition to CNS manifestation.
All right. Can you please tell me, since this patient is a known case of endometriosis, so can you define the term endometriosis?
Endometriosis is the presence of endometrial tissue elsewhere, like in the ovary, in the peritoneum, in the bladder, elsewhere apart from the endometrial lining.
Okay, why the patient experiences pain when a patient has endometriosis? Yes.
The patient experiences pain while during pass.
Okay, all right. Can you please tell me why APC gene? What is that which APC gene does normally?
What APC gene? What it does is it's an oncogene. It's a tumor suppressor gene. Therefore, it suppresses proliferation of abnormal gene cells which have abnormality within them.
Okay, last question, please. You read that patient has one ulcerated 7 millimeter large polyp. Can you define the term ulcer?
Ulcer is a breach in the continuity of an epithelial lining.
Yes, good. Right. Okay. What is the management? Last question. I said last, but then okay. What is the management that you can offer to this lady?
Okay, for this patient that has multiple polyps, it depends on the extent. If it involves the whole colon, then she would benefit from a total colectomy. But if it also involves the rectum, then she will undergo a total proctocolectomy with ileoanal reconstruction.
Okay. APC gene causes hyperplasia. That's what I wanted to do. Okay, good. Thank you. Can you describe what you're looking at?
Okay, this diagram shows multiple polypoid lesions scattered all over the intestinal mucosa.
Yes. What could this yellow be? This, if you could see this, what could that be?
Yes, ma'am, I can see it.
Yeah. Can you explain what could that be?
Okay, that could be secretion, as in secretion from the polyps.
Why these secretions are white here?
Ma'am?
These secretions, can you see here white? It's glistening. It's
yes, it's glistening on the other side.
Yeah, here.
Yes,
on the other side. Whereas here it's yellow. Could that be bile? Couldn't that be bile?
Yes, it could be. Yes, ma'am. Yes, ma'am. It could be bile, ma'am. Yes, ma'am.
Yeah, I'm ready.
Yes, and here is your question. Right, so if you have read and understood, considering this communication skills station, kindly begin. Begin, please.
I'm waiting for him.
Dr. George, please don't sleep. Can anyone poke him? Is he sleeping? Is he here or he got disconnected? All right, start, please. Begin.
Okay.
Begin, please. Bell had gone.
Okay. It's right. Hello, I'm Dr. George, one of the SC1. I would like to work in with my consultant, Mr. John. I would like to get an advice on the patient who had a right hemicolectomy for sickle tumor, but is oliguric at the moment. I would like to speak with the consultant on call. May I confirm who I'm speaking with, please?
Yes, I'm the consultant in the call. Could you summarize the case?
Okay. This is a case of a 69-year-old lady who had a right hemicolectomy 1 day ago on account of a sickle tumor. Following that, we noticed that her urinary output reduced. She has made just 10 to 20 meals per hour in the last 8 hours, and also assessing her vital signs. She is tachycardic with a pulse rate of 120 beats per minute and a blood pressure of 90/60 with a mild elevated temperature. Looking at her labs, also there's been a drop in her hemoglobin from 12 grams to 10 grams per day. Today, the urea and creatinine are mildly elevated. I have also checked the urinary catheter and realized that it hasn't been blocked. It's flowing freely, and examining the abdomen also, it's quite lax. It doesn't look as if there is anything toxic happening in the abdomen.
So what do you think about the cause for these?
Well, I think the patient is hypovolemic as due to dehydration, as she has received only 1,100 ml of fluid in the last 24 hours.
Okay. Did you check the Foley?
Sir, I didn't get that.
Did you check Foley if it's obstructed or not?
Yes, I said earlier I had checked the indwelling urinary catheter and it's flowing freely, it's not blocked.
So what's your plan for this patient?
Okay, for this patient, bearing in mind the deficits in fluid, I would like to do a fluid challenge. I would give 30 mils per kg of fluid in the first 20 minutes and reassess the and also maintain the daily fluid intake of about 2,000 mils per day since she is a lady. Then I would also observe her until tomorrow. By tomorrow, I would also assess the labs to see if there is still any drop in the hemoglobin, which I may need to transfuse her with blood to observe her following the fluid management until tomorrow.
Do you mean she's bleeding or might bleeding?
Well, she might be bleeding. From her records. She had bled in theater and had received about 2 units of blood. But I would still need to reassess the abdomen to see if it's enlarging or showing any sign, and also assess her vital signs to show if there is anything suggestive of ongoing bleeding. But in the meantime, I would like to observe her equally.
Okay. Do you think it's anastomosis leak or leak in intra-abdominal?
Well, following the abdominal examination, there are no features suggestive of anastomotic leak.
Okay. Do you want me to see the case?
Well, I would like to observe her following the fluid challenge and maintenance, and also assessing the labs, blood labs tomorrow. I would prefer to, if there is no change, I would like to inform the intensivist in the high dependency unit for possible central venous catheter to monitor the central venous pressure. If there is no change, I would still inform you and possibly invite you to come over, sir.
Okay. Do you want to transfer the case?
At the moment, I would like to do these other initial management I have discussed with you, and also see how the patient improves. If there's no improvement, then possibly we would need to transfer to the
Okay. Okay, with you.
Hello, sir.
Continue.
Yes, sir. That's my plan for the patients. Is there anything you would expect me to do, sir?
Could you tell me what is the cause for shock in this patient?
Well, if the patient is not properly hydrated, poor fluid intake could be a cause here. Bleeding, also hemorrhage could be a cause. Ongoing hemorrhage could be a cause. Or if the patient has a leak and peritonitis, septic shock could also be a cause of a shock in those patients. So basically, hypovolemia from poor fluid management, ongoing bleeding, and septic shock.
Okay. Thank you. So.
All right.
Thank you so much.
Thank you so much, sir. All right, sir.
Now ask if the HDU is full, then who would you talk to?
If the HDU is full, I would also need to inform the consultant in charge of the case. I would also discuss with the
bed manager.
Gone. Is he gone again? Gone or there? You can tell the consultant of the case. Still a few seconds left.
I think the connection with the net connection.
Yes.
Yes, I can hear you now.
Yes, please. If you can tell us who is the consultant of your case. Thank you. And here is your question. Right. So if you have read and understood, considering this surgical pathologist patient, kindly tell me what is the provisional diagnosis, excuse me, that you consider for this patient?
This patient will have probably a rheumatic heart disease with probably infective endocarditis.
How would you confirm your diagnosis?
I would like to do an echocardiography.
All right. What would you see on echocardiography?
In the echocardiography, I will be able to see the vegetations, valve vegetations.
Anything else?
Myocardial abscesses. And if the patient has undergone previous valve replacement, then a recent loosening of the valve from the stem would be seen.
Anything else? There's a whole
other
list.
Than this,
there'll be ventricular dilatation and dysfunction. There'll be pericardial
dysfunction,
effusion, reduced mobility of the nodules, annular dilatation, chordal elongation, or the rupture even. So that's quite a lot. So can you please tell me what are the criteria that you will consider that can help you with your diagnosis?
I would like to consider the Duke's criteria for the diagnosis of infective endocarditis. The Duke's criteria has been classified into major and minor criteria. Among the major criteria, we have the blood investigations of the blood cultures first.
Yes.
Among the blood cultures, we have 2 blood cultures which are positive for microorganisms, which are typically found in infective endocarditis.
Yes.
Or if we have blood cultures which are persistently present after 12 hours, or if we have 3 or more separate blood cultures positive drawn at least 1 hour apart. And this is the blood culture for the major criteria. For the major criteria of the echocardiography, we have the valve vegetations, the myocardial abscesses, and the recent loosening of the partial dehiscence of the new partial dehiscence of the valve.
All right. Can you please help me to understand the pathogenesis of this condition?
It is usually in situations where there is a defective cardiac valve or a prosthetic valve, in which there is no smooth flow of the blood over these valves. And in situations where the patient develops infections or bacteremia, or we have a bacteria in the blood, there is possibility of deposition of microthrombin and platelets around the valves. And this also deposits the bacteria along with this, and hence leads to formation of infective endocarditis.
Good. Can you please tell me or mention few common organisms that can be found?
Because we can have Streptococcus viridans, we can have group B Staphylococcus, we can have Enterococcus, and we can have the Hancke group of organisms, which will be the Haemophilus, Aggreganobacter.
Can you tell me?
Have the
what is Osler's nodes?
Osler's nodes are painful lesions present in the palms because of an immune deposition which is happening in the fingers.
All right.
Of the patient.
All right. Okay. Can you please tell me how many types of infective endocarditis are you aware of?
Infective endocarditis could be either acute or subacute. Acute is usually in damaged valves. Subacute is usually in healthy valves. We can also have the non-infective thrombotic endocarditis, also called as the marantic endocarditis, which is usually seen in case of a malignancy. Other than this, we can have the Lippmann Sachs endocarditis.
Okay, all right. Can you please tell me what are the risk factors which are involved in infective endocarditis?
First of all, congenital heart diseases, probably valvular heart disease is more common, will be a risk factor for developing endocarditis. If we have had previous cardiac surgeries or like valve replacements or any other cardiac congenital conditions for which we have had surgeries in the past, other than complete ASD and complete VSD repairs.
All right.
Previous history of infective endocarditis,
yes.
and IV drug abusers.
Okay, can you please tell me,
IV drug
yes, what are the complications that you should keep in your mind? If you don't,
the patient,
yes.
The patient can develop acute myocardial infarction.
Yes.
The patient can have valvular insufficiency, and the patient can have septic thrombi being dislodged, and that may lead to pulmonary embolism or infective pulmonary embolism. We can have blindness, myocardial, mesenteric ischemias.
Any non-cardiac complications that you can expect?
The patient may have sepsis, non-cardiac complication.
Stroke, right?
Stroke, yes, yes.
Acute kidney injury, yes. And glomerulonephritis. Okay. What should be the ideal management of infective endocarditis?
Once the blood cultures have come, we would preferably start the patient on IV antibiotics. But,
what would you do meanwhile?
In the meanwhile, I'll also start the patient on anticoagulant therapy.
What is the most common antibiotic that can be given to the patient?
Cefotaxime with vancomycin. I would start them on broad-spectrum antibiotic.
What are the restrictions that you should keep in your mind while
because it's an infective endocarditis and we have a thrombin formation already, the antibiotic may not be able to penetrate because it's deep inside. And if it is a prosthetic valve, the prosthetic valve itself may not have its own blood supply, so we may not be able to achieve a good bioavailability of the antibiotic at that level.
All right. Okay. Do you think once you have started medical management of the patient and patient is not responding, what should your next step be?
The next step will be to remove the septic foci of infection, probably do remove the valve and have a valve replacement, or plan for a cardiac replacement eventually, or cardiac transplant eventually, if it doesn't subside.
Okay, because yes, while you're waiting, okay, for the transplant, patient's congestive cardiac failure is becoming worse. Then what are the things which are most important for the matching that you'll consider?
HLA typing is important before I proceed with the cardiac transplant.
Okay, how do you, if you can tell me, how does the immunosuppressants work?
We have different categories of immunosuppressants. Basically, we have the corticosteroids, which act by becoming an anti-inflammatory and also killing the T cells. This will be prednisolone and methylprednisolone. Then we have the cytotoxic immunosuppressants, which will be the mycophenolate minoxidil. It could be the azathioprine, methotrexate. These basically kill the T cells. Then we have the immunofilling.
Even when going for the transplant, what are the things that you should keep in your mind?
The patient can develop an acute rejection of the transplant of the graft.
Okay.
If the patient has already been exposed to the antigens, then the patient can develop a hyperacute reaction.
All right.
Rejection, sorry.
Okay. Right, and to prevent these acute rejections, you'll give immunosuppressants.
Immunosuppressants. Yes, I will give immunosuppressants with the cover of IV antibiotics.
Right, and you'll also probably give steroids. So what are the consequences of giving long-term steroids that you should know?
For long-term steroids, the patient can have cushingoid features. The patient will become obese, will have purple striae, can have hirsutism. The patient
patient's outlook is not that important. The most important is that patient
the
becomes
patient's
opportunistic
opportunistic
patient.
infections for viral and
Yes,
bacterial infections.
Yes. And
The
already,
patient can
yes.
precipitate fluid overload,
Yes.
and we can have the fluid overload can be there. The patient can also develop musculoskeletal problems like arthritis and weakness of the limbs.
Yes, and can also have osteoporosis and
Osteoporosis, yes, ma'am.
yes, AVN, etc. Very good. Okay, good. Thank you. Right.
Thank you, ma'am.